Yes, ma'am, we are live.
Bismillahirrahmanirrahim. I welcome all the participants, all the audience, and all the experts on behalf of Society of Obstetricians and Gynecologists of Pakistan. It is my immense pleasure to introduce my panel of experts to you all today. My first panelist is Madam Rizwana Chaudhary. Madam happens to be a very senior teacher, an executive member of SOGP. She is going to talk about steps, complications, and indications of cesarean section. My next panelist is Madam Nahin, Professor of OPN, Chairperson Peshawar Chatter, Secretary of Academic Board of SOGP, a very exemplary personality who has taken extra time to even construct the model herself. Thank you very much, Madam, for spending your time for our members today. Madam Shahzad Professor of OPN at Gujarat College, and is the chairperson of Gujarat Global Chapter of SOGP. SOGP in the current scenario is really with its members now. We know that all the petitioners are having trouble in running their clinics, in running the services which are so essential for the patients. So keeping that in mind, we are not only talking generally about this skill, but we have a separate part on how to take care of a patient of cesarean delivery when she is COVID suspect or COVID positive. So I would like to start with the name of Allah, the most merciful, the most beneficial. I would like to convey regrets from Professor Razia Kurejo, who was supposed to be in the meeting today, but due to certain emergency in her own household, she had to be at her house today and she could not connect. She has conveyed her message of regret to all the members. We are running live. The comments and queries would be on the Facebook page of SOGP Secretariat. We will take your questions and we will put them to the worthy panelists. So over to you, Madam Rizwana, for the talk. Thank you very much, everyone, for joining in.
Thank you, Halima. Very kind of you, and I think it's a great honor for me to be talking of a procedure which is done so often in Pakistan. So to begin with, I'm just going to share a few slides, but I'm going to talk spontaneously on them. So cesarean section, as you all know, is the delivery of the baby through the abdominal route. By nature, it has to come out of the vaginal route, and there used to be a time when there was no cesarean section available. But then the mortality in those cases where the baby could not deliver was quite high. But otherwise, the rate of normal deliveries was also extremely high. But with passage of time, as cesarean section became safe, it is now becoming a dilemma. Okay, should you be doing cesarean section? There are many patients who even on demand want a cesarean section. So what should you do about them? The thing is this, that there's a huge debate which is always going on. The cesarean section rates are different in different countries and in different facilities of the same country as well. But I mean, this behas comes to no end actually. So starting with, all right, so starting with the indications, basically definition I've already expressed, and then, all right, so the indications, there are certain absolute indications, because otherwise if you do not do a cesarean section on those indications, there may be death of the mother or of the fetus. So those consist of placenta previa, especially if it's central placenta previa, cord prolapse if the baby is alive, then vasa previa, transverse sly if she is in labor and the membranes are ruptured and there is no point in doing ECV, with hand prolapse, and abruptio placentae with an alive fetus. Otherwise, in abruptio placentae, if the fetus is dead, then the aim should be a normal vaginal delivery. So these are absolute indications which will result either in death of the mother or of the fetus. But there are large number of relative indications, and these relative indications make a major bulk of the cesarean sections which we do. So that is, one is fetal distress. And different people interpret CTGs, fetal heart rates in different conditions, and they label them as fetal distress, which may be meconium, which may be a category 3 CTG, etc. But this depends upon the person who's actually doing the monitoring during labor. And then failed progress. Failed progress is another dilemma also, due to which a large number of cesarean sections are done. The patient may be just in the initial phase of labor, but she is having contractions, mild contractions, the cervix is not dilated, and many people label this as failure to progress. So all this needs a big communication. Malpresentations, for instance, breech, you may offer an elective cesarean section, or you may assess and allow a normal vaginal delivery with discussion with the patients. But other malpresentations like brow presentation or shoulder presentation, etc., they may require a cesarean section. Then malpositions, they usually result in failed progress of labor, and certain malformations such as a hydrocaph or a major malformation due to which normal delivery may not be possible. CPD is the cephalopelvic disproportion. I mean, labeling a patient as a case of CPD is also not good, because the thing is this, that she may have a cephalopelvic disproportion in one pregnancy, and she may not have it in the other pregnancy, because this is called cephalopelvic disproportion. So it depends upon the size of the baby. And then you come on to previous scar. So after previous one scar, many people do not feel safe, although it is recommended that after discussion, you can give a trial of vaginal delivery. But after two scars, usually people do not, although there are various case reports on this as well. So the timing of delivery is very, very important. If it's an emergency, it's an emergency. That really doesn't matter whether what the gestational age is, if that is an emergency. But for elective cesarean sections, the recommended time is 39 weeks, and that also you should make sure from the first available scan that actually the dates are corresponding. So it can be done anytime after 38 weeks, but the recommended time is usually 39 weeks. You can delay it even further, but then there is a risk that instead of being an elective, it may become emergency if the patient comes in labor. And it is recommended that DEXA cover should be given in elective cases. So what are the types of incisions? So one is, obviously you all know that there is an abdominal incision, and then there is a uterine incision. So there are various types of incisions which are present, and you can see this, that there was, initially it used to be a midline vertical incision, but nowadays the commonest incision is the fan steel incision, which is given about 2 centimeters above the pubic symphysis, and it's about 10 centimeters long. And then the Joel Cohen incision, this is also quite commonly done, especially in America. And this is an arbitrary line drawn between the two anterior iliac spines, and this is about 3 centimeters below that. And you can see it's just a straight line cut. And then the Maillard, which is quite high up, almost midway between the umbilicus and the pubic symphysis. And then obviously it's the midline incision. Paramedian is usually not given for cesarean sections. So these are abdominal incisions. And the other very important incision would be the uterine incision. So for the uterine incision, there is the commonest which is done is a transverse incision in the lower uterine segment. This is the commonest. But sometimes you may have to change it. So then it can be a lower uterine segment vertical incision. The transverse incision may be extended up. It can become a J-shaped incision, or it can also become a U-shaped incision if the J is present on both the sides of this. Then this is the next is the classical cesarean section, which you can see. And this is done in the upper segment of the uterus. This is usually done, I'm just going to come to that. And then this is the inverted T. So inverted T is usually done in cases of real dire emergencies when you cannot take the baby out and the baby obviously would be having distress or there's bleeding, etc. So you can extend this into an inverted T. But the inverted T, as well as the classical cesarean section, these are dangerous cesarean sections because they can lead to uterine rupture in the next pregnancy, even during pregnancy, and definitely during labor. So, but these have to be done sometimes. For instance, if there's a central placenta previa, especially an anterior placenta previa, then you should give an incision a little high up to prevent torrentic hemorrhage from the placental site. Sometimes it may be difficult to take out the baby, and especially if tubal ligation is to be done, then this classical cesarean section can be done. So another very important thing is that while you are giving this incision, there used to be a big debate between whether this should be done bluntly or it should be done with a scissor. But now the recommendation is that after giving a small incision in the uterus and the lower segment, you should do a blunt opening of the uterus in the lower segment, and your fingers should go like this. They should go a little up rather than going straight, because this can go directly into the parametrium. This can injure the uterine vessels, and there can be a lot of hemorrhage. So if you do it in a little upward manner on both sides, so this upward can be extended into a J, or it can be extended into a U if there is a problem. So then I'm supposed to tell you the steps of cesarean section. I think our main audience is gynecologists and they should know this, but I am just going to label them. That obviously first you give an incision in the skin, and this is a phalansteal incision which is being given because that's the commonest which we do. Then after the skin, it's a fat layer, and you give an incision in that, and then you can just separate it bluntly. Rectus sheath, you give an incision in the center, you hold it with the alices as it is being done in this photo, and then you cut the sheath. And in the center, it may be quite adherent to the muscle, so you may have to cut it. Otherwise, the rest of it, the rectus sheath, is separated only from the muscles. The next comes the recti muscle. So that is, I think, extremely important. And as you can see, uh, it should be up and down. Rather than doing it transversely like this, the plane is up and down, and you should just separate it, no cutting, nothing, you just separate it up and down. The main problem which occurs is that people try to pull it, and the inferior epigastric vessels, veins, arteries, they may be injured, and there can be a lot of subrectal hematoma, which is quite commonly seen in cesarean sections and causes a lot of debility to the patient. So this step is very, very important. Then comes the parietal peritoneum. You can open it with the finger bluntly, or you can give a nick in that. You must make sure that the bladder is empty, because the bladder, if it's high up and it's not empty, there's a kink in the catheter, or some people do not even put in a catheter. They just ask the patient to evacuate the bladder. But it's extremely important because in this incision, you can directly cut the bladder. So after giving an incision in this, you can bluntly open it up, and then comes the visceral peritoneum. So visceral peritoneum, some people do not separate the visceral peritoneum, but I think it's important to separate it. And then you push the bladder down, and you can have an access to the uterine layer. Then you give a nick in the uterus, a small nick in the uterus. And as I already explained, that do a blunt dissection going a little upwards like this. After giving an incision, if there is another very important thing is that since you are giving an incision with a blade, if there is less liquor or if there are ruptured membranes, there is no liquor, you may directly give the incision onto the baby's face or the head. So this is very, very important. If the liquor is enough, usually you give you see the membranes and you give a nick in that and the fluid comes out. But if the membranes are absent or there is very little liquor, then you must be very, very careful while you are incising the uterine layer. And then you put in your hand and you deliver the baby. After the delivery of the baby, it's the delivery of the placenta and the cord. Some people do a manual removal immediately, but it's always better that a syntocinon injection is given at that time. You do a controlled contraction and let it come by itself. But you must make sure that the uterus is empty. The worst thing is having retained products after a cesarean section. After a delivery, sometimes it may be acceptable, really. But after a cesarean section, to me, and I think to anybody who's doing cesarean sections, this should be unacceptable that still there's some cotyledon or small part of placenta. So you must make sure that the cavity is empty. And then comes the suturing. So this is now done in the reverse order, but before suturing, what is important is that you must clear the peritoneal cavity completely. There should be no fluid, no blood present over there. You should make sure that all packs are counted, all instruments are counted, and then you should do the stitching, right? But that obviously should be the packs and the instruments you should make sure at the time of peritoneum. But over here, you have to clean, thoroughly clean the peritoneal cavity, because if blood remains there, it can give rise to a lot of paralytic ileus, it can give rise to infection. And meconium stained liquor, if that's present, that can also produce a lot of problems. So you must clear that. It's so you don't need to wash the cavity always. You just clean it. And then suturing starts in the reverse order. The uterus has to be stitched. There's a lot of debate, a lot of papers present, and RCTs were done, but there was no difference found. But for long-term morbidity, I think it is important, even what is mentioned in the textbooks is also that it should be stitched in 2 layers. The first layer is hemostatic, the second layer embeds that, and it makes it a little strong. So the muscle layer is stitched in 2 layers. You must do a proper approximation, and then comes the peritoneum. So many people do not stitch the peritoneum. So I think, again, there are lots and lots of papers on this. It causes adhesions if you don't stitch, or it causes pain if you stitch, and the surgery time is a little longer. So I think this depends upon you. As far as I'm concerned, I always do a visceral as well as a parietal peritoneum stitching. And I have opened a lot of cases, which I have done previously, even previous 7 cesarean sections, and it was as neat as the first one. So according to my experience, I always do it. But what is recommended in the books is that if you want to do it, you do it. If you don't want to do it, it's okay. The results are the same. So then after this comes the rectus sheath. And this is the main support of the abdomen. And I think this is extremely important, what you do with the rectus sheath. This should be stitched with Vicryl. All the layers should be stitched with Vicryl. This should be also stitched with Vicryl, but if there are repeated surgeries, if the woman is very obese, etc., then it's important that you stitch this with Proline. And that will remain there. Vicryl obviously gets dissolved. So you stitch that. Now, regarding after the rectus sheath comes the fat. We are going in the reverse order now. So fat, it is recommended that if the fat is more than 2 centimeters, then you should stitch it. Otherwise, you can just leave it. But since you do subcuticular stitches, it's important that there should be no bleeding points in the fat. And the skin, for the skin, a large number of suturing is done. Staples are used, but the best recommended is Proline 20 in a subcuticular way. That gives the least pain, and least pain at removal as well, and it gives the best results. So then what are the complications? This is again very, very important, and it depends upon the surgeon and the anesthetist, and obviously the condition of the baby when you're doing, the condition of the mother while you're doing the cesarean section. So there are lots of complications of spinal anesthesia and others of general anesthesia. Because of many complications of general anesthesia, the recommended anesthesia is spinal and not general. However, in spinal anesthesia, spinal shock can occur. So the patient should be given Hartmann solution before the surgery begins. There can be a high spinal, which may require a G at the same time. Then it can be a failed spinal. As soon as you hold this patient's skin, the patient jumps. And then aspiration, that is very rare in spinal anesthesia, but sometimes when you give sedation, it may occur. Spinal headache post-operatively is quite common. Then you come on to the general anesthesia complications. The main complication of general anesthesia was aspiration pneumonia, which is called the Mendelssohn syndrome. And that is why the world reverted from general to spinal anesthesia, because that has less of problems. And then during surgery, what are the problems which can occur? These are obviously hemorrhage, which can sometimes be immense hemorrhage. Then there can be trauma to the surrounding structures, and amongst these surrounding structures, poor bladder is the most commonly injured. And then there can be difficult access if there are previous 1 or 2 or 3 cesareans which were badly done. Then there can be difficulty in delivering the baby. Sometimes the lower segment, even if the patient has not gone into labor, it may be quite thick, or in a preterm baby, or just holding the baby. So there can be difficulties in the delivery of the baby. Then extension of the uterine incision, especially if it goes laterally into the uterine vessels, can be torrential. Then obviously these are the complications which occur during surgery, right? And then there are complications which occur on the first day, which occur in the first week, and then those complications which occur later on. So usually on the first day, the main complication can be shock. And this can be due to loss of fluid, but you should always consider hemorrhage as the cause of shock. It can even be a cardiogenic shock. It can be a thyrotoxic shock. The patient may have been on steroids and she goes into shock. It can be an infective shock. It can be an anaphylactic shock. But if shock appears on the first day, you must consider hemorrhage. Then in the first week, there may be pain in the stitches, there may be hematoma formation, there may be dehiscence, there may be wound infection, there may be reduced urinary output if you're not taking appropriate fluids. Then paralytic ileus is quite common, so early mobilization and early breaking of nil per mouth should be encouraged. Then UTIs are also quite common, especially in countries like ours, where people do not let their women take water, and already this area lies in the area of surgery and the patient has been catheterized. So these are quite common. Respiratory tract infections are more common with after general anesthesia. Then there can be a fistula formation, which can be a small cut given there and then, but there can be that the bladder has come in a stitch, and this may give way later on. I think these are extremely important steps, and one must learn cesarean section appropriately. Then in the second week, usually between the 7th and the 14th day, this is the most high risk period for developing DVT. And sometimes DVT may not be there, but sudden pulmonary embolism can occur. Pregnancy is a hypercoagulable state, and with surgery, it can become really bad. So later in life, there may be pelvic congestion, there may be adhesions, there may be pain, chronic pelvic pain, which may be there, or there may sometimes be menorrhagia or irregular menstruation. There may be difficulty in conceiving if there were too many adhesions, etc. So the complications are divided into first day, first week, second week, and then late complications. And I think that is about it. So we should never take cesarean section lightly. It involves the life of the mother as well as the life of the fetus. And I think we should be very, very serious about training our postgraduates, training people, giving them proper indications to do a cesarean section, because the cesarean section rate is becoming really, really high in our country. And Robson criteria, where 10 points are taken into consideration, is extremely important. I think on the platform of SOGP, I would advise every unit to label the category of the cesarean section in the Robson criteria. Thank you very much. I'm honored to
Thank
be here.
you. Thank you very much, madam. I think it was a pleasure listening to you as always. Thank
Thank
you
you.
again. And thank you for bringing in the Robson's criteria thing. SOGP plans to have a separate
Yes,
webinar for
that
Robson's
I
criteria. We
think
will
is
do it.
very important.
I will,
That's why I just touched it, Halima, because
I
it
will definitely
requires a
invite
full
you on
time.
that,
Yeah,
along with Professor Lubna Hassan.
yeah.
It's she wanted to start it nationwide through SOGP. So thank you very much, madam, for such an elaborate presentation and comprehensive talk on the indications, complications, steps. Now may I request Madam Rehana Rahim with her team at Peshawar. Assalamu alaikum, welcome, to kindly show us the steps on the model. Thank you, madam.
Dr. Halima, can you listen?
Yes, very clearly, madam. Thank you. Please speak up. Yes.
Okay. So we are going to start with the steps which has been elaborated in detail by Professor Rizwana Chaudhary. But as we all agree, cesarean section is one of the commonly performed obstetrical procedures throughout the world, with incidence as high as 50% in most of the Scandinavian countries. And we all agree that so far there are no conclusive randomized trials for so many aspects and steps which are taken during cesarean section. So to start with, I would like to introduce my team. Dr. Hina Gul is my postgraduate trainee. We are in theater. Who's going to assist me? Dr. Mehraj is my anesthetist. Are you able to see all of us?
Yes, madam. Thank you for introducing us to your team.
And Sister Wahida is my scrub nurse. So I would like you first to have a look at the trolley. We have made two dummies because before it was not possible for us to go through the steps as elaborated by Professor Rizwana. Before going to the theater, we have done this checklist. WHO safety checklist has been introduced and many probably facilities throughout the country are doing it. This is the one which we have designed for Lady Reading Hospital. And the preoperative checklist would mean that we have identified our patient, we have put an identification band on, we have taken informed consent, we have explained the procedure to the patient along with complications, and we have clearly outlined the indication because there could be 2 or 3 indications sometimes. We have made sure that the patient, if she is going to theater in emergency, she has been given antacids and she has been given IV antibiotics. I'm going to talk about IV antibiotics a bit more in detail. She has had a pyodine vaginal wash, very, very relevant for patients who are in obstructed labor. And we have put in a wide bore IV cannula. We have started hydrating her. And we have informed the pediatrician, depending why we are going to do that cesarean section and if the baby needs resuscitation. And we have ordered blood products if indicated. So this is our pre-op checklist for emergency cesarean section. Intraoperative checklist we'll discuss when we are proceeding with the procedure. This is X. He has had acute
Please, your mic has got muted. Yes, thank you. Please go ahead.
Okay, so this is umbilicus, this is pubic symphysis, anterior superior iliac spines. Depending upon the urgency of cesarean section, we can either go for Joel Cohen incision or Pannenskiel, depending upon preferences. We have to make sure that the patient is scrubbed with pyodine or chlorhexidine. Both have been proven to be as effective in several clinical trials. the tilt, 20-degree tilt, which was recommended and has been still recommended, is not of proven value in different trials. So I'm going to give this pink is, can you see, can everyone see? This is the abdominal wall.
Yes,
I'm
very
going to
clearly. Thank you.
Yeah,